Thank you for watching this brief webinar on medication-assisted treatment for alcohol and opiate use disorders, presented by SBIRT Colorado. The Substance Abuse and Mental Health Services Administration, or SAMHSA, defines medication-assisted treatment as combining behavioral therapy and medications to treat substance use disorders. Identification begins with screening to determine risk associated with alcohol, opiate, or other drug use. Screening, brief intervention, and referral to treatment, or SBIRT, is a recommended universal prevention service. Find out more about SBIRT training and technical assistance in Colorado at improvinghealthcolorado.org. Refer to the DSM-5 for more information on the diagnosis of alcohol, opiate, or other drug use disorders. Substance use disorders are classified as mild, moderate, or severe. The Prescription Drug Monitoring Program is an important tool to identify possible unreported use of opiates. For more information on assessing a patient for the need for medication-assisted treatment, visit samhsa.gov. After an assessment, it is sometimes determined that medication-assisted treatment is indicated. Under federal law, medication-assisted treatment patients must receive counseling, which could include different forms of behavioral therapy. Medication-assisted treatment service professionals are required to acquire and maintain certifications to legally dispense and prescribe opioid dependency treatments. SAMHSA's Division of Pharmacological Therapies makes available opioid prescribing courses, webinars, workshops and summits, and publications and research for physicians. More information on becoming certified can be found at samhsa.gov. Little is known about the factors that physicians consider when deciding whether to prescribe medication-assisted treatment to their patients, but some barriers have been identified. Awareness and comfort using medication-assisted treatment among primary care clinicians can sometimes be a barrier, as well as patient awareness and likelihood of bringing up medications as an approach to treatment. Research is needed regarding the preferences of patients, but there is little reason to assume readiness for public acceptance of medication-assisted treatment, except for the possibility of positive attitudes generated from knowing individuals who have benefited from methadone treatment. Understanding of insurance coverage is another big barrier. SAMHSA put out a publication called Medicaid Coverage and Financing of Medications to Treat Alcohol and Opioid Use Disorders that can help physicians understand how medication-assisted treatment is covered by insurances. For more information or for a free digital copy, visit samhsa.gov. Another identified barrier comes from a 2009 survey of State Department of Corrections leaders, which found that medications were generally not a highly prioritized treatment service for these purchasers of treatment services. More data are needed to develop an in-depth understanding of the reasons behind the limited adoption and implementation of medications for individuals involved within the criminal justice system. The main medications involved in medication-assisted treatment for alcohol use disorder include disulfiram, acamprosate, and naltrexone. Disulfiram, known by its trade name Antabuse, treats chronic alcoholism. It is a deterrent medication, most effective in people who have already gone through detoxification or are in the initial stage of abstinence. It should never be taken while intoxicated, and it should not be taken for at least 12 hours after drinking alcohol. It does not decrease cravings, but rather will make it unpleasant to drink while taking. Unpleasant side effects including nausea, headache, vomiting, chest pains, and difficulty breathing can occur as soon as 10 minutes after drinking even a small amount of alcohol and can last for an hour or more. Acamprosate, known by its trade name Camprol, is for people in recovery who have already stopped drinking alcohol and want to avoid drinking. It is an anti-craving medication that does not prevent withdrawal symptoms after people drink alcohol. Acamprosate works by restoring the chemical balance in the brain in an alcohol-dependent person who has recently quit drinking. It has not been shown to work in people who continue drinking alcohol, consume illicit drugs, and/or engage in prescription drug misuse and abuse. The use of acamprosate typically begins on the 5th day of abstinence, reaching full effectiveness in 5 to 8 days. Side effects may include diarrhea, upset stomach, appetite loss, anxiety, dizziness, and difficulty sleeping. When used as a treatment for alcohol dependency, naltrexone, known by its trade names Revia, Depade, and Vivitrol, blocks the euphoric effects and feelings of intoxication. This allows people with alcohol addiction to reduce their drinking behaviors enough to remain motivated to stay in treatment and avoid relapses. Naltrexone is offered in pill form to be taken once per day or an injectable extended-release dose. It is not addictive, nor does it react adversely with alcohol. Long-term naltrexone therapy extending beyond 3 months is considered most effective by researchers, and therapy may also be used indefinitely. The main medications used in medication-assisted treatment for opiate use disorder include naltrexone, methadone, and buprenorphine. When used as a treatment for opioid dependency, naltrexone, known by its trade names Revia, Depade, and Vivitrol, blocks the euphoric and sedative effects of drugs such as heroin, morphine, and codeine. It binds and blocks opioid receptors and is reported to reduce opioid cravings. There is no abuse and diversion potential with naltrexone. If a person relapses and uses the problem drug, naltrexone prevents the feeling of getting high. People using naltrexone should not use any other opioids or illicit drugs, drink alcohol, or take sedatives, tranquilizers, or other drugs. Patients on naltrexone may have reduced tolerance to opioids and may be unaware of their potential sensitivity to the same or lower doses of the opioids they used to take. If patients who are treated with naltrexone relapse after a period of abstinence, it is possible that the dosage of opioid that was previously used may have life-threatening consequences, including respiratory arrest and circulatory collapse. Another risk factor is that patients try to overcompensate the lack of euphoric effects with a higher dosage, which can lead to overdose. Methadone, known by its trade names Methadose, Discets, and Dolafine, is an opioid that is sometimes used to treat pain, but is also used as a maintenance therapy or to help with detoxification in people with opioid dependence. It works by suppressing and reducing cravings for abused drugs and changing how the brain and nervous system respond to pain. It lessens the painful symptoms of opiate withdrawal and blocks the euphoric effects of opiate drugs such as heroin, morphine, and codeine, as well as semi-synthetic opioids like oxycodone and hydrocodone. Methadone is offered in pill, liquid, and wafer forms and is taken once per day. Pain relief from a dose of methadone lasts about 4 to 8 hours. Patients taking methadone to treat opioid addiction must receive the medication under the supervision of a physician. After a period of stability based on progress and proven consistent compliance with the medication dosage, patients may be allowed to take methadone at home in between program visits. By law, methadone can only be dispensed through an opioid treatment program certified by SAMHSA. The length of time in methadone treatment varies from person to person. According to the National Institute on Drug Abuse publication, Principles of Drug Addiction Treatment, a research-based guide from 2012, the length of methadone treatment should be a minimum of 12 months. Some patients may require treatment for years. Even if a patient feels that they are ready to stop methadone treatment, it must be stopped gradually to prevent withdrawal. Such a decision should be supervised by a physician. Methadone can be addictive, so it must be used exactly as prescribed. This is particularly important for patients who are allowed to take methadone at home and aren't required to take medication under supervision at an opioid treatment program. Like methadone, buprenorphine, known by its trade names Bunavail, Suboxone, and Subzlov, suppresses and reduces cravings for the abused drugs. Unlike methadone treatment, which must be provided in a highly structured clinic, buprenorphine is the first medication to treat opioid dependency that is permitted to be prescribed or dispensed in physician offices, significantly increasing treatment access. Under the Drug Addiction Treatment Act of 2000, qualified U.S. physicians can offer buprenorphine for opioid dependency in various settings, including in an office, community hospital, health department, or correctional facility. In order to prescribe or dispense buprenorphine, physicians must qualify for a physician waiver, which includes completing 8 hours of required training and an application process. Because of buprenorphine's opioid effects, it can be misused, particularly by people who do not have opioid dependency. Naloxone is added to buprenorphine to decrease the likelihood of diversion and misuse of the combination drug product. Naloxone, widely known by its trade name Narcan, is administered when a patient shows signs of opioid overdose. It blocks the opioid receptor sites, reversing the toxic effects of an opioid overdose. It can be administered by intranasal spray, intramuscular, subcutaneous, or intravenous injection. It is also added to buprenorphine to decrease the likelihood of diversion and misuse of the combination drug product. A prescriber can prescribe naloxone to patients who are in medication-assisted treatment, especially if the patient is taking medications used in medication-assisted treatment or considered a risk for opioid overdose. Providers or pharmacists can show patients, family members, or caregivers how to administer naloxone. Intravenous injection every 2 to 3 minutes is recommended in emergencies. Colorado Senate Bill 15053 expands access to the life-saving drug naloxone. As a result of the new law, the Chief Medical Officer of the Colorado Department of Public Health and Environment may issue standing orders for naloxone to be dispensed by pharmacies and harm reduction organization employees and volunteers to help expand statewide naloxone access to those who need it most. For more information, visit improvinghealthcolorado.org and samhsa.gov. From there, you can download the SAMHSA manual on medication-assisted treatment for alcohol use disorders or the manual on medication-assisted treatment for opiate use disorders. You can also find information on current Colorado opiate prescribing guidelines, as well as the newly released CDC opiate prescribing guidelines. You can also find information on applying for a buprenorphine waiver to become a buprenorphine prescriber. Please remember that under federal law, medication-assisted treatment patients must receive counseling, which could include different forms of behavioral therapy. These services are required along with medical, vocational, educational, and other assessment and treatment services. As with all medications, there is always a chance for side effects. Lists of these side effects can be found on the SAMHSA website. A list of pertinent links can be found in the comments section underneath this video. You can also contact the SAMHSA Division of Pharmacological Therapies at 240-276-2700.